Welcome to this webinar that will describe briefly the science behind pain and the treatment of pain. Many medical providers and public health professionals do not fully understand this subject. Because of this, our nation has really gotten into trouble with the use of opioids for treatment of pain. I will try to explain some of that and explain what we can do about that in the following slides. This case presentation is taken from a NIDA-Med module teaching prescribers how they should be prescribing for acute pain. I use this as an example because it clearly shows the misperception our society has regarding the acute efficacy of opioids. NIDA is the National Institute on Drug Abuse. In this module, NIDA recommends treating her sprained ankle with 30 days of opioid pain medications. We will see during this presentation that will result in increased costs and worse outcomes. In 1997, the medical community prescribed enough opioids to provide 96 milligrams of morphine to every man, woman, and child in the United States. 10 years later, that amount had increased to 700 milligrams per person, an increase of greater than 600%. Despite that increase, several studies have shown that Americans suffer just as much pain now as they did prior to our increase in prescribing. This study was in the Journal of the American Medical Association in 2013, showing years lived with disability from multiple pain complaints. Americans had more pain in 2010 than they did in 1990. Even when correcting for our aging population, Americans still suffered as much or more pain as they did prior to our experiment with opioids. There is also a tremendous societal cost to the use of opioids. A study in 2007 estimated that the United States pays about $55.7 billion per year because of opioid abuse and misuse. That comes out to about $170 per person per year for every citizen in the United States. That also comes out to about 24 cents per milligram of morphine. Calculating for a 30-pill bottle of Percocet 5 milligrams, that calculates to a cost to society of about $54. The majority of this cost is borne by industry because of lost productivity. Law enforcement and the medical community also have significant increased costs because of the opioid problem. This graph is from a report by the CDC several years ago. It shows that as sales of opioids have increased, there has been a parallel increase in opioid addiction and overdose deaths. This shows that opioid overdose deaths and addiction are directly related to our prescribing. When we look at major diseases in the United States, we see that deaths from opioid overdoses have grown tremendously over this 10-year period. Not only are we not doing well stemming the growth of opioid overdose deaths, but we are actually causing it with our pens and prescription pads. So why is it that opioids have become such a problem? As you all know, opioids are derived from the poppy plant. The poppy is a beautiful flower that is often grown along the sides of the road in the United States. This, of course, is a different type of poppy and does not contain opium. For those poppies that do contain opium, after the petals have fallen off, a seed pod the size of a golf ball remains. Opium workers cut these open, and a latex material is expressed from the center. Historically, this was dried to a white powder, which is opium. Opium contains about 80% morphine, 15% codeine, and 5% thebaine. Opium has been documented to have been used by the Sumerians as much as 5,000 years ago. Hippocrates wrote about using opium when he treated both pain and depression. As we look at this issue, it is very important to understand pain. Pain is an unpleasant sensory and emotional experience. Often those of us in the medical profession often think of pain simply as the sensory problem. In fact, the emotional component is the main part of pain perception that causes suffering. Physicians intuitively know this. Studies have shown that we use opioids based more on a patient's emotional response than the physical pain rating. You all know the story of the Wizard of Oz. I like to use this story as a wonderful allegorical reference to the actions of opioid products. As you remember, Dorothy and her friends have been through multiple difficult experiences in the dark and scary woods. Suddenly, they exit the woods and see a field of poppies in the beautiful Oz. They immediately become very excited and happy. They begin skipping, running, and singing. This is exactly how my patients presenting for treatment of their addiction describe their first use of opioids. Whatever dark and scary woods they have been living in suddenly seems to fade into the background. They get more energy, they develop confidence in reaching their goal, and life is wonderful. They seldom describe a euphoria. As you remember in the story of The Wizard of Oz, Dorothy and her friends soon become tired and lethargic. Soon they fall asleep until they are awakened by Glinda, the Good Witch, who sends snow. Back when Frank Baum wrote this book, snow was a nickname for cocaine just as it is today. Back in that time in the United States, it was not uncommon for people to use opium products, and if they became too sedated, they would reverse the effects with cocaine. Many of my patients describe a very similar pattern of drug use today. As we continue to look at pain, it is also important to understand that there are two completely different types of pain. Acute pain lasts for less than 3 months, almost always has an identifiable source, and generally gets better with healing of the injury. Chronic pain is totally different. It is often very difficult to diagnose the exact source. It'll last for longer than 3 months. One of the most significant differences between acute and chronic pain is the fact that the emotional component is much more significant in chronic pain than it is in acute pain. As we look at treatment of pain, we generally have 5 major treatment options, including acetaminophen, NSAID medications, opioids, topical agents, and non-pharmacologic treatment. As we look at the side effects of some of the oral medications, we all know that acetaminophen can affect the liver. It may also affect mood in the gastrointestinal tract, although usually not significantly. NSAIDs, of course, can cause gastrointestinal ulceration and irritation, renal dysfunction, and have cardiac effects. We commonly consider opioids the safest option because of the potential risks of NSAIDs and acetaminophen. Opioids, however, have very significant side effects. In fact, the opioid side effects are less well known but are more dangerous. These side effects include mental impairment. Whether taken acutely or chronically, opioids can cause mental impairment. This can be dangerous for somebody driving a car or working in a safety-sensitive position. It can also be significant in the elderly who may have some mental impairment from aging already. Opioids will delay recovery from both surgery and injury. Often opioids are prescribed following surgery to reduce pain and improve rehabilitation. In fact, there is no science to support this. In fact, a number of studies have shown that the opioids delay recovery, and there is a new movement called enhanced recovery after surgery that tries to eliminate or minimize any opioid use following surgery, and patients using this protocol recover significantly sooner with less medical costs. The use of opioids following surgery or injury may increase medical costs as much as 30%. A little-known side effect of opioids is that they may cause opioid hyperalgesia. This is an increased sensitivity to pain and may be one reason why they delay recovery. This can begin with acute prescription, but may also be the reason why many people started on opioids for chronic pain have a hard time stopping them. A large review of workers' comp cases has shown that the use of opioids within 6 weeks of a workplace injury will double the risk of disability 1 year later. This becomes a significant risk when prescribing opioids for acute pain. This is probably because of the delayed recovery and the opioid hyperalgesia effects. Opioids may increase the risk of falls in the elderly. This risk may be increased by a factor of 4. It also increases the risk of fracture a similar degree. There is some evidence that the opioids increase the risk of cardiac and gastrointestinal side effects similar to the NSAIDs, with similar risks especially in the elderly. Opioids can treat depression. I list this as a side effect because this is a very short-term effect. Opioids are very good antidepressants, but only with initial use. Unfortunately, when the opioids are stopped, there's a rebound depression that may be worse. Many of my patients that I treat for addiction got started on them because their depression got better with their first prescription, but they continued to need higher and higher doses for the same effect and soon became addicted. Studies have also shown that opioids cause significant and permanent brain changes. These include changes to the opioid receptors, but also changes in neurotransmitters and neural connectivity in the brain. A recent study looked at people who had been on morphine for 1 month and showed changes that were visible on MRI. After the morphine was stopped, these changes persisted on a follow-up MRI 6 months later. Many of these changes may be permanent, and this explains why most people need medication-assisted treatment with methadone or buprenorphine following addiction. It is also very important to understand that even short-term use of opioids can lead to addiction. For children who received a legitimate prescription for an acute injury or for dental pain, the risk of future addiction increases between 30 and 300%. Many of my patients tell me they felt as though they were addicted with their first acute prescription. As we consider pain treatment, and addiction, it is very important to understand the opioid receptors. We often think of them simply as something to receive the opioids we prescribe, but we have opioid receptors in our brains for a purpose. These are activated by our own endogenous endorphins, and their main purpose is to enable us to achieve a short-term goal. That's very important to remember. They do this by decreasing pain, increasing motivation, increasing confidence, increasing reward. This is actually a dopamine effect. They reduce depression and anxiety. They increase the pleasure in our current activity. They also increase a phenomenon called warmth liking, which gives us a pleasurable feeling when we are holding a hot cup of coffee on a cold day or taking a warm shower after being out in the cold. It is the same reaction that causes a warm feeling when we fall in love or experience a feeling of personal bonding with friends. Many of the effects from our endogenous opioid system can be extremely rewarding when taking opioids in certain individuals who may suffer from anxiety or depression, poor social situation, stress, or who may have a genetic predisposition to addiction. So if opioid medications are so dangerous, then what can we use? The Cochrane Organization is a nonprofit organization that looks at efficacy of medications for multiple purposes. They have looked at the use of medications for treatment of acute pain. Their measurement looks at 50% pain relief from medications as successful pain relief. This is done because most patients feel happy or are satisfied with 50% pain relief. If they have 30% pain relief, they notice some improvement, but it does not seem to be that significant to them. 20% pain relief is oftentimes not even noticed as improvement by patients. So the 50% pain relief is the goal. And the Cochrane Organization has looked at different medications to see how well they relieve the pain in patients, at least 50%. So if a medication is given to a person for acute pain and their pain goes from an 8 down to a 4, that's considered 50% improvement and is adequate treatment. If it goes from an 8 to a 3, it is also adequate. If it goes from an 8 to a 5, it is not adequate. So they've looked at a number of different medications, and these are actually comparative studies that looked at multiple different double-blind studies at these doses for acute pain, oftentimes after orthopedic surgery, because that's a very controlled environment. So when they looked at 200 milligrams of ibuprofen, which is one over-the-counter ibuprofen tablet, they found that 37% of people were able to achieve 50% pain relief with that dose. When they looked at just acetaminophen 500 milligrams, that's one extra strength Tylenol, they found that 28% of people had pain relief. When they looked at doubling the dose of ibuprofen to 400 milligrams, they found that 40% had adequate pain relief, or 50% or more. So this is very important to understand, because actually as we see going to higher doses, even 800 milligrams, that pain relief does not improve that much. So the higher doses of ibuprofen are not much more successful in relieving pain. They do improve reduction in inflammation. So if inflammation is a problem, higher doses may be needed, but higher doses have the side effects we worry about. The lower over-the-counter doses of ibuprofen are very safe and should generally be used for pain treatment. When the Cochrane Organization looked at 15 milligrams of oxycodone, which is a pretty hefty dose, they found that only 21% of people had adequate pain relief. So the pharmaceutical companies understood that oxycodone by itself was not very good, so they have combined it with acetaminophen. This next study looked at 10 milligrams of oxycodone plus 1,000 milligrams of acetaminophen, which is roughly the equivalent of 2 5-milligram Percocet pills, and they found that 37% of people have adequate pain relief with that. Notice that's exactly the same as the number of people that got pain relief with 200 milligrams of ibuprofen. So 2 Percocets are no more effective than 1 over-the-counter ibuprofen for pain relief. So finally, they looked at a combination that is frequently used in Europe, and that's combining 1 over-the-counter ibuprofen, 200 milligrams, with 500 milligrams of acetaminophen taken together at the same time, and they found that 62% of people receive adequate pain relief for this. So this is what I recommend to my patients, and this is what I recommend to doctors to use for acute pain relief. And that can be post-operative pain relief. It can be post-injury pain relief. The over-the-counter doses of ibuprofen and acetaminophen taken together are very effective and very safe. Even for severe pain such as renal colic, a 2005 Cochrane review concluded that NSAID medications and opioids have equal effectiveness in the treatment of acute renal colic, but that opioids have more side effects. So even for kidney stones, we should be considering using non-opioid medications first. So even the studies from the pharmaceutical industry confirm that NSAIDs are better. This graph is from the company that makes Nucynta, looking at multiple doses of Nucynta, which is also tapentadol, versus placebo, versus 60 milligrams of morphine, and versus 400 milligrams of ibuprofen. This study shows that the ibuprofen is the most effective of these options, even more effective than 60 milligrams of PO morphine. Recent CDC guidelines have stated that if opioids are to be used for acute pain, then they should generally be used for 3 days or less. In a study done by the National Safety Council, they showed that 99% of physicians prescribed opioids for longer than 3 days for acute pain. For chronic pain, it is important to remember that there is no evidence that opioids are effective for long-term treatment of chronic pain. We often hear about the safe and effective use of opioids for chronic pain, but this is an invalid concept. There is no evidence that these medications can be safe at any dose, and there is no evidence that they are effective for chronic pain. Epidemiologic studies have shown that those on chronic opioid therapy have a worse quality of life than those with chronic pain who are not on opioids. The American Academy of Neurology has recommended against the use of opioids for chronic back pain, headaches, and fibromyalgia. They state that the risks are almost always greater than the potential benefits. This graph comes from a pharmaceutical industry study looking at the long-term use of tapentadol for chronic pain. Notice the study duration was 15 weeks, and the final improvement for tapentadol compared to placebo was less than 20%. Pain experts consider 20% as the minimally clinically effective dose. Even the pharmaceutical industry studies show that there is no significant effectiveness resulting from the long-term use of opioids. We must never forget additional treatment in chronic pain. I will point out that of all of these modalities, counseling may be the most important. Mindfulness training and CBT for pain can both result in significant improvement in pain. Likely this improvement will be greater than any medication we can use. This really goes back to the fact that chronic pain is much more of an emotional and thought disorder, and it is imperative that we provide mental health treatment. I do want to make sure and mention that there is a lot of misunderstanding regarding the treatment of opioid use disorder. For those individuals who do become addicted to the opioids, they do have significant and oftentimes permanent brain damage and brain changes. For that reason, detox and abstinence has an extremely high failure rate. Probably less than 10% of individuals can achieve long-term success with this. Methadone and buprenorphine are both medications used to treat opioid use disorder and have significantly higher success rates. These are the treatments of choice for people with opioid use disorder. These are not substituting one addiction for another, as many misinformed individuals may state. This is legitimate medical treatment that treats the biochemical disorder of the disease of addiction. Naltrexone is an opioid receptor blocker. It is an option that should be used only in very highly motivated individuals. As I mentioned earlier, the opioid receptor is an important part of our brain, and blocking this receptor does result in much higher rates of depression, anhedonia, loss of motivation, anxiety, and difficulty with interpersonal bonding. Finally, I want to mention that for everyone on chronic opioid therapy, we should consider periodic tapering. Tapering people off of opioid medications generally results in about a 20% decrease in pain. This is not an easy thing to do, as initially pain will get worse because of the opioid hyperalgesia and withdrawal effects. However, with intensive counseling and medical and social support, people can be successful getting off of these medications and have less pain with a better quality of life. 250,000. It's the number of deaths in the last 20 years from opioid overdoses. That's more than 4 times the number of American deaths in the Vietnam War. This is an epidemic, and the medical community is the vector. We must take control of this situation. This epidemic is completely reversible with a change of behavior that can result in better pain management. Finally, I want to end with a quote regarding this situation from Franz Kafka. To write prescriptions is easy, but to come to an understanding with people is hard. Unfortunately, I think our society has become much too focused on taking a pill and not working through our problems. We need to change that paradigm to treat pain better and to save many lives in our community.